Assalamu alaikum everyone and good morning. I welcome you all to the 23rd Annual Shaukat Khanum Symposium. My name is Dr. Hina Makbool. I am currently working as a consultant pathologist in the Department of Histopathology, Shaukat Khanum Hospital, Lahore. I will be the moderator and co-chair for today's session. First of all, I would like to invite Dr. Samina Zaman to chair the session with me. Dr. Samina Zaman is a brilliant pathologist working as Head of Department of Pathology in Children's Hospital and Dean of Basic Medical Sciences. She is also working as a visiting consultant in Chuktai Lab, Lahore. Dr. Samina Zaman, I welcome you to join us, please. So we have two pathology sessions today. The first session has two lectures of 45 minutes each. And without further ado, I think we should move on to the first lecture. The first lecture would be presented by Dr. Anwar S. Raza. The topic is interesting cytology cases. She is the professor of pathology at Loma Linda University School of Medicine in America. She is well recognized for her educational contribution and was awarded the Best Teacher Award as well. She has published numerous articles and has presented extensively nationally and internationally. So over to Dr. Anwar S. Raza.
Some cases that I thought would be interesting for teaching purposes. The first case is of mediastinal lymphadenopathy, and a patient presented with mediastinal lymph nodes. We were called to assess adequacy. So these are some representative aspirates, and notice that we have these spindled nuclei, as you can see here, and here's some inflammatory cells and some elongated nuclei here as well, so-called carrot-shaped or, nuclei here, and there was some sort of streaming effect as well. So when we see something like this, we say, well, yes, it's lesional, it's adequate, it does not look like a normal lymph node. And with these carrot-shaped nuclei, we think about granulomatous disease. So what we saw were these elongated nuclei, maybe some multinucleated giant cell. And here's a representative histologic section showing multinucleated giant cells and this sort of granulomatous, these epithelioid histiocytes with these elongated nuclei, and notice the lymphoid cells in the background. So basically what we saw were non-necrotizing granulomas, and it was sent for stains and cultures for the usual bacteria, mycobacterial disease, and fungi. And all of the stains came back as negative, as did the cultures. So when we have these non-necrotizing granulomas, that are negative with the usual granuloma markers, acid-fast, PS, GMS stains, as well as some of the cultures, you have to think about sarcoidosis. Sarcoidosis is a multi-system disorder that predominantly affects the lungs, where it is responsible for most of the morbidity and mortality. Oftentimes, this associated hilar and mediastinal lymphadenopathy, as in our case. Other sites that can be affected in particular are the skin, eyes, lymph nodes, also the CNS, salivary glands, etc. It's well known that sarcoidosis is more common in African Americans as well as Europeans of Scandinavian ancestry. The etiology has long been suspected to be unknown, and but there's a lot of reports in the literature and studies that point to immunological susceptibility in certain individuals to exposure to Cutibacterium acnes. And that organism is very prevalent, but certain people are genetically susceptible, and they come up with a chronic response to that. So you have these so-called non-necrotizing granulomas, as you can see here. It's a very epithelioid, and you can see the multinucleated giant cell. And also in sarcoidosis, you can see Schumann bodies, asteroid bodies as well. So sarcoidosis basically is a diagnosis of exclusion. You first have to exclude other granulomatous inflammatory causes. Make sure it's negative for mycobacteria, fungal, usual parasitic organisms, and also maybe granulomatosis with angioitis. The granulomas of sarcoidosis should not show necrosis, or if they do, just minimal focal necrosis. If you see greater necrosis, then you really have to suspect a non-sarcoid etiology. And the diagnosis of this is most secure when you correlate with the clinical and radiologic findings. There's often multi-system involvement. We see non-necrotizing granulomas, and it's negative for cultures with the usual organisms. And so what about this Cutibacterium acne organism? All right, so there's been reports that when they do molecular testing on these sarcoid granulomas, they find a Cutibacterium acne showing up in that. At first, they thought it was just a contaminant, but too many studies have shown that, which is why we now think that it is caused by Cutibacterium acnes, but then some people are susceptible, and they launch an immunological response to that. And I had recently signed out a case of mediastinal lymphadenopathy, and I did the usual stains. I saw these non-necrotizing granulomas, and I said, well, it fits best with sarcoidosis. And when I called the pulmonologist, he said that was his working diagnosis as well. I think about a month later, the same patient underwent biopsy of CNS lesions, and my colleague, who's a neuropathologist, called me and said, hey, I've got the same patient that you diagnosed sarcoidosis on in the mediastinal lymph nodes, and I really think there's CNS involvement by sarcoidosis. How do I prove it? So I told him about Cutibacterium acnes. This it used to be called Propionibacterium acnes organism, but for some reason they've changed the name to Cutibacterium. And I said, that's the etiological factor. So he was able to send that brain tissue for a special molecular testing, and he was able to show the presence of Cutibacterium acnes organism in the CNS lesions as well. So, which helped him say, yes, this is a case of neurosarcoidosis. So at the time of Rose, rapid on-site evaluation, we told the clinicians it's adequate. We see granulomatous inflammation. We don't see metastatic carcinoma and do not see lymphoma in these lymph nodes. However, remember, Hodgkin lymphoma may have granuloma. So you want to look around to make sure you don't see any of those Reed-Sternberg cells. So once we said it was granulomatous inflammation, additional passes were sent for cultures, and we obtained a good cell block, and that was stained up. So the final diagnosis was granulomatous inflammation, rule out sarcoidosis. The next case, a 52-year-old man presents with a posterior neck mass for 2 months, about 2 cm. Patient fell warm and didn't look well. The aspirate was performed and yellow, creamy, purulent fluid was aspirated. And of course, some of this was sent for cultures. So when we saw the smears, we said, well, this looks like acute necrotizing inflammation. So our diagnosis was acute suppurative lymphadenitis, and we requested them to correlate with the patient's microbiologic studies. That's when we received a call from the clinician and said, you know what, could you please test this aspirate for mycobacterial organisms? We said, sure. So we did an acid-fast stain, and lo and behold, we saw those acid-fast organisms, as you can see over here. So, typically when you think about mycobacterial TB, mycobacterial infection, you think about granulomas, maybe with caseous necrosis, and more chronic inflammation. Here, the epithelioid histiocytes, multinucleated giant cells, epithelioid histiocytes, and caseous necrosis here. You don't really think about acute necrotic inflammation as being something classic for tuberculosis, but I'm sure all of you are probably more familiar with that presentation than we are here in the West currently. So what about mycobacterial infection with neutrophils? It's seen in early TB infections, also in immunocompromised patients. It's much more common for us to see mixed inflammation with acute and chronic inflammation. So whenever you see these kind of smears, perform stains and tests and cultures for bacterial organisms, and please also include mycobacterial and fungal organisms, even when the lymph nodes show significant acute inflammation. So that was a good learning case for us. And so lymph nodes with suppurative necrosis, we can see that in infections and, of course, all, various infections, bacterial, etc., but also TB early infections or in advanced disease in patients who are immunodeficient because of a high bacterial load. We also see suppurative necrosis in lymph nodes in patients with cat scratch disease due to Bartonella hanseatic infection. And in those cases, you can do a Ward and Starry stain to highlight the organisms. You can also see suppurative necrosis in some metastatic tumors, particularly squamous cell carcinoma and colon carcinoma. In squamous cell carcinoma, with the keratin, there may be also a granulomatous response. So you may just think it's granulomatous or suppurative lymphadenitis and miss the squamous cell carcinoma. And some of these can also be cystic. So squamous cell and colon carcinoma should be something to look out for. This is to show some aspirates from a lymph node with cat scratch disease. There's acute inflammation, these stellate necrosis. And if you do a Ward and Starry stain, you can identify the Bartonella organisms. So our interpretation at the time of Rose was it was adequate. We saw acute suppurative inflammation, and we took cell block for stains, and then we also sent aspirates for culture. The final diagnosis, particularly after the phone call, and we did the mycobacterial stain, was mycobacterial lymphadenitis. The third case, this is one that I'm particularly proud of because we diagnosed this on fine needle aspiration. We had an 18-year-old male present with massive cervical lymphadenopathy, as you can see here, and FNA of these lymph nodes was performed, and this is what we saw. We saw scattered lymphoid cells, as you can see over here. maybe a large nucleus there. And then it was much more obvious on the Papa-Nicolau stain. Notice you have scattered lymphocytes, and here you have a large cell. Here's the nucleus, and in the cytoplasm, you can see these smaller lymphocytes, but they are intact. They're not being destroyed. So this is an example of emperipolesis. So when you hear the word emperipolesis, massive lymphadenopathy, so which disease would come to mind? Rosai-Dorfman disease, also known as sinus histiocytosis with massive lymphadenopathy. Patients present with large bilateral cervical lymphadenopathy and fevers, usually young patients. The cause is unknown, and they suspect a viral etiology. Again, an aberrant immune response is suspected in these individuals. And if you were to stain these lymph nodes, you would notice that the plasma cells are polyclonal and also the lymphocytes. So they're reactive rather than neoplastic. They are dilated lymph node sinuses, and the very characteristic feature is to see the emperipolesis. Oftentimes, these lymph nodes undergo spontaneous resolution. In some cases, patients may need to be treated with steroids, or if they don't respond to steroids, some chemotherapy. So initial interpretation was adequate, and we saw lymphoid tissue. And of course, we took a sample for flow cytometry just in case. But then the final diagnosis, particularly after seeing the PAP slides, was Rosai-Dorfman disease, and it did fit with the clinical picture. And we made sure to show our hematopathologist, who also gave his blessing. And so it saved this young patient from having and sort of incisional biopsy or excision of a lymph node. So we were able to come up with a diagnosis on fine needle aspiration. Next case, a 56-year-old man presents to the emergency department with a history of weakness, vomiting, major weight loss. And then he complained of a food being stuck in the esophagus after eating. Imaging was done, and that showed thickening of the distal esophagus and proximal stomach. And on endoscopy, a large ulcerated circumferential mass was seen involving the proximal stomach as well as the distal esophagus. And also by imaging, they were noticed this was regional lymphadenopathy as well. So fine needle aspiration and biopsy was performed. And this is what we saw. We saw there was a very cellular, most of the cells are single, maybe some aggregates of cells, as you can see here. Here's the Papa-Nicolau stain, again showing a predominantly single cells with eccentric nuclei, as you can see here, maybe something in the cytoplasm there. And this is the cell block, again showing these similar cells with something in the cytoplasm pushing the nuclei to the edge. And in some cases, we could even see sort of signet ring cells with sort of sharp edges of the nuclei. So at the same time that they did an FNA of the mass as well as the lymph node, they also did a biopsy of the mass itself. So the regional lymph nodes were sampled by needle aspiration. And what we saw was similar metastatic adenocarcinoma, excuse me, in the lymph nodes, as well as in the stomach. and distal esophagus side. So at the same time that we got the diagnosis of malignancy in this patient, they were able to stage the patient, say, there is regional lymphadenopathy as well. So this is an example of polycohesive or that diffuse type of gastric adenocarcinoma, which is a very aggressive lesion with a poor prognosis. There's a rapid metastasis and maybe quite chemo-resistant. So it can be sporadic or familial cases. And one thing to be aware of, we've seen a few cases where there may or may not be a history of breast cancer and they do gastric biopsies. And on gastric biopsy, we see signet ring cells. So just before being conclusive that this is primary stomach carcinoma, always think about, well, could this be metastatic, particularly breast? And there may not always be a history of that. And particularly if you see that the tumor is below and it's not really involving the surface, it's sort of percolating below, always if in doubt, it's a good idea to throw immunostains to diagnose metastatic disease rather than calling this primary signet ring carcinoma. Oh, let's see what happened. Okay, so the interpretation was it was adequate, and we saw metastatic adenocarcinoma in the lymph nodes. The final diagnosis was metastatic carcinoma, and we saw similar tumor in the gastric biopsy. And at some points about staging, only call something malignant outright at the time of rapid on-site evaluation or frozen cells. Based on what you tell them, if you say it's definitely malignant, they may decide not to do any other sampling, maybe abandon surgery or say, well, this is not a surgical candidate. So make sure you're very, very certain about your diagnosis. Okay. All right, so next case, a 44-year-old man with a recent diagnosis of IDH mutant anaplastic astrocytoma presents to the ENT department. He was being worked up and they found a hard 3 cm submandibular mass. So he was sent to the ENT surgeon who aspirated that, and I was asked to do a rapid on-site evaluation. So I saw something like this. I said, well, it's lesional. It looks like a small round blue cell tumor. And I called the surgeon up and I said, well, you do have lesional tissue. However, please make sure that you do additional passes for a cell block because I'm going to have to do stains to try and determine what this lesion is. And then he told me something very important here. I knew that the patient has a history of anaplastic astrocytoma. He said, well, it's really hard and it's more skin-based. So that was a really important clue. He told me there was skin-based. And when I looked around in one area, I saw a multinucleate giant cell. And that's a really good clue. Okay, so you see small round blue cell, multinucleate giant cell. And so I had a pretty good idea what it was. And I told my screening cytotechs when they get the cell block to particularly look for certain cell types to cinch the diagnosis. Some more of the aspirates from that lesion. So see how cellular it was. You see lots and lots of these tumor cells. Couldn't really make out what was going on here. Again, scattered cells, maybe a hint of multinucleation, okay, but very, very cellular. So this was actually an example of Pilomatrixoma. The clue that I received from the surgeon was because I was concerned about the small round blue cells. And then I did see, and he said it's skin-based. So I know that Pilomatrixoma can be a pitfall. And the multinucleate giant cell to me was a clue. But the best thing, you don't often appreciate those on the smears. They're much easier to pick up and identify on the cell block are these ghost cells, where you have these small round blue cells and then keratinization, and then the nuclei are lost, giving rise to these ghost cells. And then because of the keratin, there's multinucleate giant cell reaction. Okay, some more examples of pilomatrixoma, small round blue cells. Here you can see abrupt keratinization, and then these superficial cells lose their nuclei, giving rise to these ghost cells. You can see here multinucleate giant cells as a response to the keratin being produced. So pilomatrixoma is most of them are benign, and you usually see them in young adults in the head and neck and upper extremities. And you see basaloid cells, small round blue cells, that's a huge pitfall. And then the squamous cells, and particularly these ghost cells with these empty spaces with the nuclei. And oftentimes it's a multinucleate giant cells because there's a foreign body reaction to the keratin. Sometimes it may be superimposed calcification as well as ossification. Here's a pilomatrixoma. And so the best clue is if you did the aspirate yourself, or if you were told that, hey, this thing is very skin-based lesion, and that's what would you think of? Normally you think about young children. This was a slightly older individual with a significant CNS tumor, but the fact that it was skin-based, and I saw the multinucleated giant cell, and on the cell block, the ghost cells, I was able to call this a pilomatrixoma. So it was not metastatic disease from his CNS tumor. And this is the month of October, so here's some ghost cells. So the interpretation was adequate. I said, there is lesional tissue, give me a good cell block. And I was able to call it a pilomatrixoma. There was no metastatic carcinoma. In fact, I did the rows, and the next day, my colleague had this case, and I said, hey, can I look at that? Because I was really curious to see whether we could see the ghost cells on the cell block. And my colleague had quickly looked at the case and said, oh gosh, this looks like something with stains. I said, no, I think it's a pilomatrixoma. And I took the case and I was able to highlight those. So same as doing stains. However, if you were to do stains, beta-catenin is something that's positive in pilomatrixomas. Okay, next case, a 23-year-old woman with right-sided facial tenderness and pain for 4 months, and had a sensation that the eye was sticking out. So she was this young college a student who was a cheerleader, and she was really in quite distress. She went to the emergency department, and they suspected infection and gave her some oral antibiotics, but there was no resolution. So she was next sent to ENT, and the ENT surgeon noticed there was a 2 cm mass in the zygomatic area with surrounding sort of bruising. A CT was ordered, and that showed a destructive bone lesion, and the differential by radiology was, well, it could be a primary bone or soft tissue tumor, such as a sarcoma. But then it could also be inflammatory or an infectious lesion. So this zygomatic mass was aspirated. And this is what we received. So definitely cellular, you have these very large cells, like, as you can see over here. Okay, so notice these large cells, rather large nuclei, maybe some lymphocytes in the background. Here you can see an eosinophil, and over here, maybe a multinucleated cell, but definitely lesional tissue. Okay. Here's another part of that aspirate, again, inflammatory cells in the background, but then you have these large cells with these big nuclei. Here's there's a little bit of a kidney-shaped nucleus, a little coffee bean. There's a longitudinal groove over here as well. Okay, and then here, longitudinal groove there as well. And here's a clue. In other areas, you have these large cells, as you see here, but then you could also see some multinucleated cells. Here's one, there's another one, and then also these large cells. So so based on that, we're asked for a good cell block, and that was obtained. And so the differential diagnosis, well, it didn't look like an abscess. So, we ruled out osteomyelitis. And, if it's a sarcoma, it could be, is it a rhabdomyosarcoma, osteosarcoma, could be a rhabdoid tumor, could be a carcinoma, hematopoietic malignancy. Melanoma should always be in your differential, or could it be something else? So here again, these large tumor cells that are there. And then stains were performed, and was negative for keratins, and the muscle markers were negative, melanoma markers were negative as well. So again, melanoma negative, keratins negative, P63 negative, and then CD45 was positive, CD30 was also performed, and S100, CD68, and CD1A were all positive. So again, these are the tumor cells that you see over here. So based on this, what is your diagnosis? I mean, here's the diagnosis there, right? So this is an example of Langerhans cell histiocytosis. And this is proliferation of Langerhans cells. It's more common in childhood. It can involve the nodes as well as the extranodal sites, particularly bone. Our patient had a zygomatic lesion. Again, this is supposed to be due to some immunologic dysfunction. There's human herpes virus 6 connection in this as well. And it can be monoclonal or non-monoclonal, and that's seen in the lung in smokers. Most cases harbor a BRAF mutation, as well as other activating mutations. If it's just unifocal disease, the prognosis is excellent. However, if there's a multisystem or multifocal disease, then you have more adverse prognosis. And the BRAF mutation, we had a different patient who had Langerhans cell histiocytosis, various skin lesions, and then also had a thyroid enlargement. So she actually had papillary thyroid carcinoma as well as Langerhans cell histiocytosis in the thyroid itself. And then both the PTC, papillary thyroid carcinoma, and Langerhans histiocytosis have this BRAF connection. So if I didn't know that the patient had a history of Langerhans cell histiocytosis, it's very easy to just say, oh, there's papillary thyroid carcinoma, and not see the Langerhans cell histiocytosis in the background. And if you do the stains, you can see that. Okay, so LCH, you have those kidney-shaped nuclei with these longitudinal grooves. You can see eosinophils in the background and multinucleated giant cells. And to confirm your diagnosis, a CD1A, a Langerhans, and S100 are positive in these histiocytes. CD68 is also positive. Excuse me. So the treatment is steroid therapy, either locally or systemic steroid treatment, or you could do resection for single system disease or curettage of isolated bone lesions. In more advanced cases, radiation or chemotherapy. And for those with pulmonary LCH, they should be advised to stop smoking. And these are the Langerhans histiocytes, the characteristic zipper-shaped pentalaminar sort of bodies, those racket-shaped with that zipper-like appearance. Again, those elongated kidney-shaped cells with longitudinal grooves, and you may see the eosinophils in the background and multinucleated cells. So your differential would be infections, sarcoma, leukemia, other histiocytic lesions, and you can do stains for that. Langerhans sarcoma is when you have really pleomorphic, highly atypical cells. So in this case, our interpretation was that it was adequate, and we had lesional tissue in favor malignant. But final diagnosis was Langerhans cell histiocytosis and not malignant. So the surgeon, when I called him, say, hey, this is just Langerhans cell histiocytosis, he told me, well, the other pathologist said it was malignant. And I told him, oh gosh, it looked terrible. It looked really ugly on the quick stains. And they were supposed to take the patient to surgery. But once I told him it's Langerhans cell histiocytosis, he called her into the clinic. He injected steroids locally, and she showed a really good response with just a local steroid injection. So that's good. Now, tumors in cirrhotic livers. So whenever you have a cirrhotic liver and you see a tumor, you should think more primary first, hepatocellular carcinoma, cholangiocarcinoma, combination of these, or maybe angiosarcoma. And the reason is in cirrhotic livers, there's altered blood flow, so it's less likely to have metastases from other body sites. And you can do stains for HCC, and then also stains for cholangiocarcinoma. This is an example of hepatocellular carcinoma with these widened trabeculae. They look like liver cells, but the plates are widened. There's endothelial rimming. And cholangiocarcinoma looks like an adenocarcinoma. Oftentimes a lot of sclerosis, maybe necrosis with that. And you can do stains and correlate with that. Now, one of the most common tumors metastatic to the liver was colon carcinoma, and here is an example with sick-shaped nuclei. And the dirty necrosis, it's trying to form glands, as you can see here. And so you can also do immunostains. So CK20 would be positive in colorectal carcinoma. Now, this next case, a patient presented with a liver mass, and that was aspirated. So it showed lots of spindle cells. So when I did the markers, it was negative for the vascular markers, negative for muscle markers. Melanoma markers were negative, and just c-KIT. KIT was positive, so CD117. So based on that, I said, well, I think it might be metastatic GI stromal tumor. Can you just check the patient out for a GIST? And then at tumor board, they said, this patient has a remote history of ocular melanoma. Could this be metastatic melanoma? So I said, okay. And then when you look at it, it's sort of spindle cell, but it was negative for HMB45 and melanate. But remember, spindle cell melanomas are negative for HMB45 and melanate. You need to do other markers. So SOX10 and S100 was performed, and that was positive. So at the time of Rose, I said it's adequate. It's a spindle cell tumor. And I was favoring metastatic GIST, but then once I found out patient had a history of ocular melanoma, and with additional stains, we were able to diagnose metastatic spindle cell melanoma. And this was many years ago, and that's how I remembered, oh, well, kids is positive in more than, also in melanoma, as opposed to something, you just think about GIST or mast cell disease, etc. And then that reminded me of our surgical book that always said, I think it was Bailey and Love, beware of the patient with a glass eye and an enlarged liver, because melanoma many years later tends to metastasize to the liver. So talking about KIT-positive tumors, so, it's normally present in the interstitial cells of Cajal, etc. But then look at all these tumors that are positive for c-KIT, of course, melanoma as well. And then I just found that even Giardia will stain with c-KIT. Next case, a 20-year-old woman presents with multiple thyroid masses. She had a history of GI biopsies and a significant family history. Her family members also had GI symptoms. And this is what we saw. The FNA of the thyroid mass showed these groups of thyroid follicular cells. Didn't really appreciate any colloid, and they're very tight groups, sort of you have this sieve-like appearance here. Look at these sheets of cells here and this tight-knit group of cells. So we said, well, it's lesional tumor tissue. It looks like tumor. And, make sure we get a good cell block. And the patient had a history of GI biopsies. So the gastric and duodenal biopsies showed these adenomatous lesions. So this patient had a familial adenomatous polyposis. And the tumor that's seen in the thyroid in young women with FAP is cribriform morular thyroid carcinoma. And you can see various and particularly cribriform growth patterns. And this absent or scant colloid formation. It used to be called a variant of papillary thyroid carcinoma, but they put it into its own category as tumor of uncertain histogenesis right now. The good way to identify is if you do beta-catenin staining, there's diffuse nuclear and cytoplasmic positivity, both in those associated with FAP and in sporadic cases of this. TTF, ER and PR are positive. PAX8 is negative, and it has cribriform growth and lots of these squamoid morules. The morules would stain with CD10, CD5, and cyclin B1. Here's an example where you can see these tumor cells. These are those squamoid morules that you can see here. Notice the absence of colloid. Okay. Sometimes you can see a cribriform pattern, squamous morules, and beta-catenin shows strong nuclear and cytoplasmic positivity. So interpretation was adequate lesional tissue. And the fact that I know the patient had FAP, I said perhaps it's the FAP-associated thyroid tumor. The other differential was papillary thyroid carcinoma. The final diagnosis was cribriform morular thyroid carcinoma, which is associated with FAP. And the patient's strong family history and her own personal history of FAP was a good clue for us as to what the neoplasm was. Okay, let's continue. Next case, a 29-year-old male with Down syndrome, a 24 cm retroperitoneal lower quadrant mass was present, encasing the major vessels. And the patient also had extensive adenopathy and with matted lymph nodes, and they really thought this is something malignant. And this is what the aspirate looked like. You had these scattered tumor cells, as you can see here. So the top diagnosis was, it has to be some sort of leukemia, lymphoma, could be melanoma, some sort of carcinoma or something else. So we obtained a material for stains and then for flow cytometry, and we got a heme consult. Well, flow was negative. Heme looked at this and they worked it up for lymphoma, leukemia, and it was negative again. So and the cytokeratins and EMA, these were negative as well. So what do you do next? This is not in this case, but this is another case of this, but here's a little clue. These tumor cells are very fragile, and when you smear them, you get these streaks, so-called thyroid background. Notice these large tumor cells and then small lymphocytes in the background, okay? Well, that thyroid background, but in this case, we didn't have a thyroid background. But in young adults, always think about germ cell tumors. So some of the germ cell markers were performed, and lo and behold, it's positive for kids, SALFO, OCT, and PLAB, as well as D240. So this is an example of seminoma. So it's seen in young adults as the most common type of germ cell tumor with excellent cure rates, very radiosensitive, and the prognosis depends on stage and comorbidities. On cytology, you have these cellular aspirates, dispersed tumor cells, dual population of these large germ cells, as well as lymphoid cells. And these seminal cells have lots of glycogen. And when you spear them, these cells break up, you have bare nuclei and this linear streaks, a thyroid background. And you may see scattered syncytial trophoblasts, and seminoma can focally have granulomatous inflammation. Your differential diagnosis, because of the way it looks, would be lymphoma, leukemia, as well as carcinoma. And then these, you can do serum levels for LDH, PLAP, and HCG. These are the positive stains for seminoma. And what are the risk factors? Ethnicity is more common in white population. Also, if there's a family or personal history, and also in genetic disorders, Down syndrome, and our patient had Downs. And also if the patient has cryptorchidism or microlithiasis, and also in patients with altered immune status. So what are some of the tumors seen in Down syndrome patients? You have hematopoietic lesions such as leukemia, ALL, and also acute megakaryoblast leukemia. And then lymphomas, as well as in infants, the transient myeloproliferative disorder. There's increased incidence of testicular tumors, especially seminoma, particularly if they have cryptorchidism or microlithiasis. But they can also get CNS and other tumors, but however, there's decreased incidence of other solid cancer types in Down's patients. And I think, well, perhaps they don't lifestyle, they don't have as many risk factors, but actually it's trisomy chromosome 21. On that, you have an angiogenetic factor, so maybe that is protective for some of the tumors. So our interpretation was polydifferential malignant neoplasm. They were really thinking it was lymphoma or leukemia, but the final was seminoma, which was metastatic to the periaortic lymph nodes. Because remember, the gonadal blood supply and lymphatic drainage, the gonads embryologically, they arise higher up and they descend in the body. So the first nodes to be involved in metastases would be the periaortic lymph nodes. The take-home message in young adults, always think about germ cell tumors, and then also Down syndrome.
My sincere thanks for your exceptional presentation at this event, Dr. Raza. My favorite cases were the Pilomatrixoma and the Rosai-Dorfman disease. She presented yesterday as well, so her contribution has been really valuable. And with this, I think we should move on to the second presentation of the event. The second presenter is Dr. Momin Siddiqui, who has expertise in the area of surgical pathology, mainly cytopathology, with special interest in application of ancillary and molecular techniques in cytology specimens. He has published extensively in reputable journals. He is professor of pathology at Weill Cornell University. He serves as director and chief cytopathology at PAPS Cytology Lab. He is also the president of American Society of Cytopathology, and today he would share his insights in pulmonary pathology.
Shaukat Khanum Cancer Symposium being held in Lahore today. I would like to thank the organizers for this invitation. So I currently work as a cytopathologist. I'm the chief of cytopathology at Weill Cornell in New York. And in this context, I will be speaking about pulmonary cytology and using that as a baseline for our operational workflow, terminology, and molecular diagnostics on cytologic samples which are obtained from pulmonary lesions. And the reasons for this is mainly because our volumes in this area have gone up significantly since the introduction of EBIS procedures. And I wanted to discuss that to basically elaborate more on what our workflow and operations entails. Hopefully you will find that beneficial. The disclosures are included here. I don't have any financial conflicts of interests to declare. So in the context of pulmonary cytology, our main specimen type that we obtain in our laboratory are fine needle aspirations. Majority of them are procured through endoscopic bronchial ultrasound-based procedures, which are also known as EBIS. But for those, we obtain adequacy assessment on these samples to optimize our final diagnoses. So for that, a rapid on-site evaluation is performed by our team, which can basically comprise of the cytotechnologist who will be upfront on location, on site, in the bronchoscopy suite, where with the help of a microscope, the smears are evaluated and reviewed. However, the process now entails telepathology as well, meaning thereby that I, as a pathologist overseeing a cytotechnologist who is on location, on site in the bronchoscopy suite, I can also participate with the help of a successfully implemented telepathology program, which we implemented about 8 years ago in our practice, which basically has resulted in procuring more diagnostic specimens than prior to the implementation of having the pathologist be present on all locations, on all sites, all the time. And that basically entails the introduction of telepathology. Here is our workflow. You can actually see when the call is received that a procedure is about to be conducted in the bronchoscopy suite. Our cytotechnologist picks up the paperwork, then takes that to the cytopathologist in their office. They preview the patient history and chart. And then on location, you can see in the lower column, basically the microscope is there. Along with the microscope, there is also a tablet on which the image from the microscope can also be noted for the bronchoscopist or pulmonologist to review in real time. However, when you look at the next picture on the right-hand side in the lower column, this is the actual desktop in my office where I, as the pathologist, am reviewing the same slide in real time and providing help to facilitate and procuring an optimal sample for our clinicians. This can be done through Microsoft Teams. If not, then with the help of an iPhone, one can communicate with the cytotech on site as well. This has really helped us in participating in these procedures in multiple sites. In my hospital, these procedures are being done in 3 different buildings and 6 different locations. So I can basically be present to participate on these rapid on-site evaluations as the physician in charge for these procedures, overseeing them in real time simultaneously. So one thing to note is operator experience basically equates a successful outcome. Here is a lesion. Basically, it's a large lung mass, spiculated, irregular outlines, basically indicates a malignancy. And here it's actually a CT-guided needle which had been placed. And based on the needle's placement, one would assume that an adequate sample would be procured from this patient. Let's see more on that a little bit later. But these patients, when we obtain these specimens, can, along with fine needle aspirations, also include exfoliative samples such as a bronchial brushing, bronchial wash, bronchial lavages, along with a tissue core biopsy. These are not necessarily procured every time, but based on the adequacy assessment of the fine needle aspiration, the pulmonologist may or may not obtain additional sampling of a core biopsy at the same time. So these are the gamut of the specimens that we do get to see on our service, ranging from FNAs to exfoliative samples to tissue biopsy. The tissue biopsy in some practices can be kept together along with the FNA samples to provide a composite report for the clinicians and the oncology team. However, in more subspecialized institutions, the tissue biopsy may get split and be sent to surgical pathologist if there is a subspecialist in that area who is providing care for these patients. So how does one obtain adequacy in real time? Obviously, in real time, smears are procured. These are basically, as you can see in the image here, these are rapidly stained after air drying with a diff quick stain, which is basically a Giemsa-based stain, and takes about less than a minute for the smear to be prepared and reviewed. So this is basically giving an overall assessment of specimen quantitation, and also some metrics of qualitative features of the lesional tissue are also noted in these smears. Aside from this basic adequacy assessment, triaging the specimen into a neoplastic, non-neoplastic, or non-diagnostic categorization, additional smears are also obtained for apneic stained smearing for laboratory-based staining, which are reviewed at a later stage. Those smears and stains basically give a better evaluation of the nuclear details of these lesions. So the next thing to basically procure is the residue from each aspirate sample, which is basically the residue coming out of the needle, which is not smeared. And from that, we procure a cell block. And that is noted over here on the right-hand side in the lower corner on the right. So those are some of the portions that are coming to cytology for further review later on. There are many factors which include and influence diagnostic yield of these aspirations. Definitely the type of the needle employed. The bigger the bore of the needle doesn't necessarily mean a better sample would be obtained. Site of the tumor, lymph nodes, it's also basically very relevant. Number of aspirates, generally 5 needle sticks are optimal. If more are being performed, chances are that more will not necessarily be useful, because essentially at that point, the needle would be procuring much more bloody samples. So basically the samples which are ideal for us are for the first 3 needle passes, which basically yield a more optimal sample. Then obviously ability and experience of the operator, in this case of the pulmonary medicine physician or the interventional radiologist, are also very much a feature and a factor that influence the diagnostic yield. Specimen handling, this is a great reference, which basically is a composite of recommendations from multiple societies, including the American Society of Cytopathology, College of American Pathologists, which basically entails how these specimens should be handled. Obtaining an adequate sample basically involves good smearing techniques, basically involve also not just collecting for a diff quick smear sample, but also for pap stained smears to be looked at, and also how a cell block is collected and utilized later on. And again, I'm again want to emphasize that rapid on-site evaluation is very helpful, because if these procedures are done without interpretation in real time, then the final outcome of these are fairly unpredictable, because one doesn't know what one is obtaining in real time. Multiple different methodologies are in play here. EBUS I've already flagged out, but along with that, navigational bronchoscopy has also become fairly common as a modality, which incorporates both ultrasound as well as CT guidance as a combined modality for having the needle approach the lesion itself, which may actually be somewhat peripheral as well. And very small lesions can also be assessed quite successfully by implementation of navigational bronchoscopy. But by and large, most of our procedures are EBUS directed. Transthoracic core biopsy has less of a play now for us, because peripheral-based lesions can still be procured through these other two modalities, and mostly the most extreme cases where they are very much peripherally located would a transthoracic core biopsy would be employed to evaluate the lesions. I already talked about the immediate assessment as to how to assess it by making the smears, air drying them, and staining them. They can be applied both for the primary lung mass, if that is being aspirated. If that's too small and difficult to assess, then mediastinal lymph nodes, if they are enlarged and suspected of disease involvement, specifically in malignancies, then those can also be assessed and used for primary diagnosis of the tumor itself. This is what a smear looks like, but in this case, we have what you see is mostly blood, and few rare lymphocytes are noted in the background. So essentially, this is going to be called inadequate or non-diagnostic for evaluation in real time. Similarly, here you can actually see with the arrows pointing towards clusters of cells and the background showing extensive necrosis, that three-dimensionality and pleomorphism of the cells indicate that we have lesional tissue consistent with an adenocarcinoma. So this smear will be deemed in real time as adequate for assessment. Along with immediate assessment, then additional passes are also needed, especially in the context of pulmonary malignancies, and these are mostly directed towards procuring an ideal cell block once an immediate adequacy has been rendered and deemed to be adequate. For diagnostic purposes, a cell block in our practice is important for further workup. Cell block methodologies for processing are multiple, as you can see from this long list here. Colloidal bag, histogel, plasma thrombin methodology are all available, and all can be utilized in a given laboratory. However, we use the clotting method. So what it entails is fairly an easy way to understand. Whatever the residue from the needle is placed on a glove and on a gauze, which has been placed on an additional slide. So if 4 passes have been procured from a lesion, the residue from all 4 passes after the smears have been made can be placed on this piece of gauze, and this residue is allowed to clot, such as what you can see here now. So this basically in the end is placed in a formalin and allowed to fix. And once that is done, then a tissue paper can be wrapped up in for paraffin embedding and processing for a H&E section done by the histology laboratory, and can essentially be treated as a histologic or a biopsy sample. It's equivalent to that. So the clotting method has its advantages because each and every cell is saved for this procedure, and it's simple. Greater tissue preservation is ensured, and then immunohistochemical and molecular studies can also be performed on these cell blocks with great ease because they have been fixed in 10% buffered formalin. So shifting gears here, so that was about operational workflow. How do we report these lesions? Recently, that World Health Organization came out with the reporting system specifically for lung cytopathology, which categorizes these FNAs into 5 diagnostic categories, ranging from a non-diagnostic all the way down to malignant. Each of these entities has corresponding diagnoses attached to them. For instance, the benign category includes inflammatory reactive lesions. Also, it includes the benign neoplastic lesions, such as a pulmonary hematoma, a sclerosing pneumocytoma, even spindle cell tumors and granular cell tumors are included in this category. Atypical and suspicious are fairly self-explanatory, and malignant includes all the non-small cell carcinomas along with neuroendocrine tumors and carcinomas and lymphoproliferative diseases in this categorization. So this is the structure that has been given out by the WHO. This is the first category, which is non-diagnostic. What it means is that the specimen that has been obtained has no diagnostic utility and basically is deemed non-diagnostic and not useful for further management. Now, there can be many reasons for this. Mostly it's just blood being procured, hence there's limited cellularity, or artifacts can be introduced, especially if it's a diff-quick or pap stain slide where proper fixation has not been obtained prior to further processing, such as if diff-quick is not completely air-dried but stained as a wet smear. Simultaneously, if a pap stain smear was not rapidly placed in alcohol, but allowed to air dry and then placed in alcohol. So those are some of the issues that we have to contend with. This is an example of what would have been an ideal diagnostic specimen. You can see the cells are there, but these are all really enlarged and difficult to interpret because this diff-quick stained smear was not allowed to air dry completely. Similarly, if the blood clots are impacting the review of the cells which may be entrapped within them, then that can be deemed as a non-diagnostic specimen as well. Similarly, crush artifact where the cells themselves are very fragile and the technologist or the pathologist smears them with undue great force or pressure, then they can smear quite and basically become distorted quite easily. Similarly, if only bronchial cells are obtained, which are basically picked up along the trajectory of the needle, then that would not basically be representative of the lesion itself, but more like a trajectory-induced procurement of benign elements and would be called as non-diagnostic. Benign category includes inflammatory processes such as pneumonia, abscesses, granulomatous inflammation, and there's a long list of benign neoplastic entities which are included here. For instance, these are basically flat sheets of what appear to be very monotonous basaloid cells. This would basically correlate with benign sampling of the lesion itself. And again, similarly, benign bronchial epithelial cells and macrophages, as are noted here, would represent a benign process because in the background, you can see that there are quite a few lymphocytes present in the previous slide as well as in this current slide, which represents an inflammatory lesion. Similarly, macrophages, these can represent pneumonia or resolving pneumonia, and by themselves would be deemed as a benign categorization of the lesion if it has been thoroughly sampled, and this is all what we are obtaining. This is an example where, as you can see, this air-dried smear shows quite a few fibrovascular structures to which the cells are adherent, but right in the middle, when you see them, they're mostly macrophages, which are adherent to the proliferating capillaries. Here, the same image from the on a papinicula stained smear where the nuclear details are better appreciated and the macrophages are better appreciated. So this would correlate with almost like a granulation tissue-like picture, but in the context of lung. And if this is a solid lesion, this would represent pneumonia or resolving pneumonia, and not to be misinterpreted as atypical or anything higher than that, such as a malignancy. Similarly, non-necrotizing granulomas should certainly give rise to a variety of possibilities, whether they are inflammatory or infectious. They can further be worked up appropriately. Similarly, this is an example where this was a very cellular sample where coming from a well-circumscribed mass in the lung. Again, proliferation of capillaries, so it's vascular. And when you look carefully, there are quite a few areas where you can appreciate what looks like fibroadipose tissue, along with spindle cells and larger cells. So this is, again, a situation where an unusual finding can be detected in the lung as a primary diagnosis, which can be rendered based on the cell block assessment of a PICOMA. Unusual entity for this location, but we do see them periodically in our practice. Similarly, when you find myxoid material along with dispersed nuclei, which are far apart, not showing any atypia, you have to look at them carefully. This is again a cell block and the pap stain smear demonstrating what looks like benign cartilage. So this would be representative of a pulmonary hematoma. Similarly, in the next case I'm showing you here is an example of what looks like an organoid pattern with cells which are somewhat spindle, but these cells are showing discrete processes which are coming out and forming tails. The cells themselves are interdigitating and can't really tell the boundaries of these cells one from the other. So what does this entail? To the neuropathologist in the audience, they can probably recognize it. Here, basically, a little bit more of rounding up of the cells. A whirling pattern can also be noticed and is very prominent in the low power image on the right-hand side. But again, the monotony of the cells indicates that this is somewhat of a benign entity we are looking at. So this is an example of a meningioma representing some benign lesions which we can come across in pulmonary pathology. Category 3, based on the WHO categorization, is atypical. Again, basically what this indicates is that we cannot tell what the lesion represents. There are insufficient features here based either on quantity or quality that we cannot really slot this lesion whether into a benign or a malignant process. So that is basically the essence. And an example would be when during an EBUS procedure, we find flat sheets such as what you see over here. These clearly look squamoid in appearance. So if that is the question, then are we dealing with a squamous cell carcinoma? But the pleomorphism and the nuclear atypia that is associated with a squamous cell carcinoma is completely lacking here. So in this context, we can certainly call this atypical. And in this case, we could get a biopsy confirmation in real time that this represented squamous metaplasia. Suspicious for malignancy is a category which is to be used when we have truly malignant cells which are identifiable, but we don't have a qualitative or quantitative comfort that can be attained on the sample that we are observing. And let me show you some examples. These are 3 images here. Left one is a District stain smear. Middle picture represents a pap stain smear. And on the right-hand side is a cell block. Again, these are different cases, but in these cases, these were the only cells that were obtained as either sheets or groups. So on that basis, since certainly the pleomorphism, the nuclear atypia associated with the malignancy can be noted in all these 3 preparations, but due to quantitative aspects being so limited, definitive diagnosis of cancer cannot be rendered. Positive for malignancy here, when the sample is well obtained, then there should be no reservation in making a call on a cytologic specimen. Again, some statistics from 2023 for which we have the entire year's data. Again, estimated deaths in the United States for both lung and bronchus in both males and females still heads the list of cancers which lead to mortality, and estimated new cases are decreasing somewhat and still occupy the second place for both males and females. And but number of deaths basically gives you a context as to the presence of the disease that we have to contend with as practitioners within pathology or other subspecialties which may be managing or treating these patients. So moving into the next topic here, and here I move into the WHO classification of thoracic tumors. This is the last printed version from 2021. This is based on histologic classification on which our cytology WHO classification is based. And again, I would refer to this as a text for the pathologists in the audience to certainly work with and to study, to basically understand pathology diagnoses, and again, to have an idea about what it entails to be a cytopathologist working in the context of thoracic tumors based on the main WHO classification of tumors, which basically came out in 1967, where resections and morphology alone was the main method being used for diagnosis of these tumors. But in 2021, the WHO's main blue book has also included small biopsies and cytology samples, and have placed a much broader emphasis on genetic testing, along with morphology, which still remains paramount for classifying these tumors. There have been a few changes and updates in the 2021 WHO Blue Book. Again, there is a much broader emphasis on genetic testing. There is recognition of some newer entities such as SMARC-A4 deficient undifferentiated tumor, update on neuroendocrine neoplasm classifications, etc. So again, I leave this to your convenience to review this text and to have at least an acquaintance with what's available out there in the literature. Also, how has the WHO classified these tumors? The first one is, of course, the list of adenocarcinomas, the precursor glandular lesions such as atypical adenomatous hyperplasia and AIS have been included in this classification of adenocarcinomas, along with the various subtypes of the tumors themselves. And the list is here. Similarly, the same applies for squamous cell carcinoma, but here I want to focus on terminology such as lymphoepithelial carcinoma, where this was previously an independent diagnosis, but based on 2021 WHO classification, it is now listed as a squamous cell carcinoma subtype, and hence treated accordingly. Large lung neuroendocrine neoplasms also have been looked at, precursor lesions, but main neuroendocrine tumors that pose a challenge, especially for small biopsies as well as for cytology, remain the carcinoid tumor, which are basically two in categorization perspectives, such as the typical carcinoid and the atypical carcinoid. And for the carcinoma, the small cell carcinoma and the large cell neuroendocrine carcinoma are worth noting here for categorization purposes. So this is a brief snapshot of the 2021 WHO classification. So just want to introduce the new tumors that have been introduced, such as thoracic, SMARC-A4 deficient undifferentiated tumor. Also take a look for the adenomas. Again, these do not apply to cytology, but definitely for small biopsies and resection samples, they do matter. And the new entities that have been introduced here are the bronchiole bronchiole adenoma, and the ciliated muconodular papillary tumor. So these are some of the guidelines for good practice of small biopsies and cytologic preparation based on the WHO classification. What basically is being recommended that non-small cell carcinomas should be further classified into more specific types, such as an adenocarcinoma or squamous cell carcinoma whenever possible. The term non-small cell lung carcinoma should be used as little as possible. This can be done quite easily if you have a good sample based on morphologic assessment as well as immunohistochemical staining. And based on that, the term non-squamous cell carcinoma should not really be used for most reporting purposes. It should be used only where morphologic assessment or immunohistochemical results do not definitively characterize these tumors. Hence, when paired cytology and biopsy specimens should be reviewed together and, if possible, signed out together. If not, communication between cytopathologist and surgical pathologist is very important for a concordant diagnosis for that patient. One word of caution I want to flag out that the terms AIS or minimally invasive adenocarcinomas should not be used for diagnosis of small biopsies or cytology specimens because it is generally not possible because of limitations in morphologic assessment. These, by and far, these diagnostic categories end up getting signed out as adenocarcinomas based on the sampling. This would be an example of lung adenocarcinoma, three-dimensional groups of cells displaying pleomorphism, gland formation. Cellularity is appropriate on this discrete stained smear. So on site, this would be quite easy to recognize as adequate and representing an adenocarcinoma, higher magnification showing you cytoplasmic vacuolation, and in the background of three-dimensionality and pleomorphism, this would be a very easy diagnosis to render. Similarly, on the papinicular stained smear, the morphologic features of the nuclei are better assessed and show significant coarseness of the chromatin along with prominent nucleoli, which are also helpful for diagnosis. Last but not the least, this is the cell block, which I had described earlier. I'm looking at many cells correlating with the smears, which I have just shown you. And this is also going to be very helpful for working up further for immunohistochemistry. Another point of view here that sometimes small pieces of tissue which look like core biopsies can also find their way as part of the FNA scores. FNA cell block procurement because of the needle bore being larger, and then we can actually really look for invasion even, but that is not a call that we make on cytology. TTF1 stain, this is a nuclear stain used to confirm a diagnosis of a lung adenocarcinoma, then it's positive. So what is the difference between adenocarcinoma and significant reactive atypia, which may be noted, say, in a pneumonic consolidation? So I have given you a list here. You can certainly look at it later on as part of your handout, but take a look at the chromatin. Those would be the features which would separate the two. In malignancies, chromatin in the nucleus tends to be irregular, whereas reactive atypia tends to be more fine rather than coarse. And nucleoli tend to be more prominent, exhibiting themselves as macronucleoli in adenocarcinomas, and that is not a feature noted in reactive atypia. This is an example of a keratinizing squamous cell carcinoma with extensive necrosis in the background. Take a look at the nuclei. They look really
कर लिया
I would like to thank Dr. Momin for an excellent and fantastic presentation as always. And I apologize, but due to time crunch, we have to stop the video before finishing. Um, um, I think it's time to conclude the session, but before that, I would like to request Dr. Samina to say a couple of words or to add something.
Okay. Thank you so much for having me. And I must acknowledge and appreciate the efforts of the conference organizer for their hard work and dedication for putting this seminar together. And these type of the forums or the platforms, they provide us the opportunity to foster the knowledge exchange and also provide us the opportunity to meet with our colleagues from the different institutions and from the different cities of the Pakistan as well, and with the international colleagues as well. I must pay my heartfelt gratitude to our speakers, Professor Anwar S. Raza from the Loma Linda University, California, and Professor Momin T. Siddiqui from the Weill Cornell Hospital, New York City, for sharing their knowledge, for sharing their expertise, and presenting excellent presentations and making them so simple and understandable. And you must all be knowing that the College of Physicians and Surgeons has recently started second fellowship in cytopathology, and such conferences and workshops can go a long way in developing this subspecialty in the Pakistan. And in the end, I also want to thank all the attendees for their participation and for attending this workshop and seminar. And once again, thank you so much for all to the organizers, to the guest speakers, and to the attendees. Thank you so much.
Thank you, Dr. Samina. Unfortunately, Dr. Siddiqui and Dr. Raza are both not available for question and answers. So if you have any questions, you can forward them to us and we will ask them and let you know. And with this, we conclude our session. Thank you, everyone, for joining us. Thank you so much.